1.2 billion people in 2025 will be over the age of 60. This is an incredible achievement for public health. We should all congratulate ourselves for what we have done to extend both the standard of living and the quality of life for people all over the globe. Essentially, where you are today, you're going to live 20 years longer than the people who were born in 1950 lived where you are. So, of course, there's tremendous variation as well, right? Not all of us are living to 77.1 years. But it suggests that the issues we took on as a policy measure in healthcare worked to improve quality of life and standard of living for billions of people across the globe. It's also set us up for one of the biggest healthcare challenges of the 21st century. And that is, how do we improve the standard of dying and the quality of death in the next 25 years? 50 years, let's say. So I think initially we go with the cost issue here. And if I were Jane McGonigal, I'd have like all these numbers, and I'd be working numbers, and I'd come up with like $1 or something. But essentially what you want to think about here is, if we just talk about the US, not because it's representative of how countries pay for healthcare and end-of-life care, but because it might be the system we all know best here. If we just talk about the Medicare population today, on average, we spend about $4,000 per person in Medicare. But the year you die, Medicare will roll out $25,000. In other words, government will pay $25,000 on average for every enrollee who dies in Medicare today. It's about 5% of the Medicare population in total. About 1 million people die. If we think about what that's going to look like in 2025, when we've got 9 million people over the age of 85, depending on what percentage you're comfortable thinking will die in the 10 years that come, that following decade, we're somewhere around $200 billion just in death care. So this is not talking about pain medication. This is not talking about treatment. This is just the money the government outlay that will come out to cover death care. So there's a financial piece to it. But I think for this group, the challenge I want to bring forth is really a much larger question about getting comfortable with death. I'm looking at Lynn because she does all this work in China, and it's like the Chinese, from my understanding, they can't even talk about the topic, and it's going to be this tremendous impact on government funding for China in the next century. But I want to bring back the idea that, right now the conversation is really about end-of-life care. People say, oh, we need more palliative care, or we need more hospice. But I think the larger question for us is, how will we know when we're dying? When you think about what's going to kill most of us, it's not going to be something that has a clear, there's no more cure, there's nothing else we can do, you can now transfer to hospice. When you die from diabetes, when you die from cardiovascular disease, when you die from dementia, when you die from Alzheimer's, only retrospectively will we be able to say, oh, that was the month before you died. That was the 6 months before you died. So we need to start to think about, what will standard of dying look like at the policy level in order to answer that kind of question. Today, when you ask doctors, they'll say, that we've heard there's tremendous research in this area where you ask senior oncologists to look back at their patient populations, those who have died, and say, in hindsight, who was overtreated? Which of your patients would you not have treated the way you did had you known that they were going to die on a certain date? Anyone have a guess of how many patients doctors feel should not have received treatment? Zero. Senior oncologists do not recognize overtreatment. They think that every patient they were treating, there was a chance, there was a possibility. So it's clear that we need this larger conversation about what is the standard of standard of dying and quality of death look like as we become an aging globe. So I'll just bring it back to the conclusion here, Sean. So if we think about what we did in the 20th century, if you think about the initiatives we took on in public health and education to change the story about what kills us, to change childhood illness that used to kill us, maternal mortality, and granted, these are still issues today. I'm not trying to suggest that we're all going to live until 80 years old. But if we put that same attention, if we put dying and the quality of death in the bloodstream of policy moving forward, we may do what we did for public health for public dying.